week we talked about bone histology. We start talking about different types of bone. And somebody can remind me, we classify the bone histologically on two types. Can anybody tell me what it is? One at a time. Someone there is his hand, you talk, then you just listen. He said
Woven
woven bone
and lamella.
lamella. So what's the difference?
I was going to say cortical bone and trabecular.
It's based on the location, but histologically we classify them into woven and lamella. What's the difference?
Lamella is parallel organized, woven is random.
What's the random, what's organized? What is the structure that's organized and what's
Parallel
random?
fibers.
Hmm?
Parallel fibers.
Yeah, what fibers?
Collagen
Collagen fibers. Is the orientation of the collagen fibers. If they're random, yeah, random structure, but what is exactly random? So the random structure is the collagen fiber, the type 1 collagen. So if they're random, it's a woven bone. So if the bone is not mineralized yet, what do you call this? Somebody raise his hand.
Osteoid.
Yeah, somebody raise his hand. Raise your hand. Yeah, osteoid. What's osteoid? It's unmineralized. What's made of?
Made of rich collagen type 1.
Yeah, collagen mostly and others, non-collagen, and so on. So you said something about the classification of bone, trabecular and cortical. So what are the differences and what this type of classification? Is this histological classification?
It's locational.
Yeah, location because you can see it. You can take the bone, you cut it, this is cortical. What's the difference? Where is the cortical, where is the trabecular?
The cortical bone is found at the edges of the.
Yeah, the cortex, supposed to be the shell. Yes.
Yeah, the shell, the big shell of the bone.
Yeah.
And it is made of mostly of lamellar bone and organized. Or no, it is.
No, be careful here.
Compact
Yes.
lamellar bone. It's made of osteoids. It's composed of osteoids.
Osteo. So what's the trabecular bone? You. No.
Spongy in the inside of the bone.
Yes, where is it? It's certain place in the bone. Please don't talk when the others are talking. You sent me a question, correct? I'm supposed to be about it.
You find it in the diaphysis of the bone?
Epiphysis and diaphysis.
Yes.
I'm sorry, metaphysis, not the diaphysis. That's the shaft. It's empty. The bar. Where else can you find it? Yeah, there's bones. The vertebra. You have to remember the vertebral body is mostly trabecular bones. So he said something about lamellae. So is both cortical and trabecular bone lamellar or not?
Yes.
Yeah, if they are mature, they have to be lamellar. Just the structure, as I said, the osteonal structure is going to be only in the compact bone, but the lamellar structure, the osteos are lamellar, but concentric lamellar. So the lamella is layer. So if you have the layer parallel or rounded as a concentric, it doesn't matter, all lamellar. But the special feature about the compact bone is those lamellae making those osteons, which has a central artery and then all these lamellae layers around them. Right? So what are the cells that exist in the bone? We said three main ones. Somebody from this side. You. Yes. You always shake hands with me. So yeah.
I should have.
Yeah, in the lab, in the exam,
Yes,
many
exactly,
times.
sir.
Correct? I don't forget. I don't know your name, but I know your face. Tell me, any cells in the bone? We have three major ones. Let's give him a chance.
Okay, so osteocytes,
Yeah,
osteoclast, and osteoclast.
Yeah, excellent. So what's the difference between the two? So he brought you a flower. So what's the difference between these cells?
The osteocytes between the ear.
Yeah, they sit inside the bone matrix cell. They have a function? Anybody know?
Osteoclast,
No, osteocyte. What's the
osteocyte,
function?
Maintenance.
Mechanical sensor. Yeah, when you carry things like that, you know, this will sense to tell you how much load you have. The other cells, the osteoblast, what the osteoblast does. You need to remember this. This is not something you should forget.
I think they're progenitor cells for the osteocytes.
They are, but they're not called progenitor. When they retire, they get embedded, we call them osteocytes, but it's not called progenitor. Progenitor has a specific name. It means it's another one that deliver another one. It's not. Yeah, somebody else.
it makes the osteoid not acceptable to the bone.
Yeah, what is that? It makes the bone matrix, basically, yeah, it makes the collagen deposit. The collagen, it's like fibroblasts making the matrix of the connective tissue. So osteoblasts are the fibroblasts of the bone, but they have a special name because they're making different bone. You always talk, you always talk and you talk. You sit here, you talk, here you talk, here you talk. Please. I told you it irritates me. Unbelievable. Forget the other question. Osteoclast, what do they do?
Osteoclast.
Skip, okay, yeah. So you give you a gift, yeah, osteoclast.
Osteoclast. Is it the one that's
There are only three: osteoblast, osteocyte, and they talk about both of them. The third one, no, not use. Wait.
perhaps repair?
osteoclast. Yeah.
They drill holes in the.
Yeah, they resorb the bone. They don't drill. I mean, yes, they resorb the bone. This stuff you can't forget. So today we'll be talking about more of the bone. And you have to read this before they said biology. It's going to be trouble for you to understand what I'm talking about. Please. You want to answer questions? This is my PhD students, so they attend here, so they better know this. So these are today's learning objectives. We talked today about bone remodeling. You know, the word remodeling means that you're going to change something. You're not rebuild something, but rather replace old stuff with a new one. When you remodel your home, you change the sink, you change the bathroom, and you put a new one. So the house is still the same, but you keep patching, or you change the color of this painting and so on. So this process is called remodeling, and we have the same thing in the bone. Basically, it means that you're replacing the bone. So we remove old bone and replace it with a new one. Every individual, every 10, 15 years, you replace your whole skeleton. You get a new one. So in your age, probably this is your second one. And my age probably is like, I don't know, 15 or something, I'm 150. So this is happening both at the cortical and trabecular bone. So the remodeling process, and we said before, the majority of the volume of the bone is cortical, 80%, 20% only trabecular. But when it comes to metabolic activity, like remodeling, 80% happening on the trabecular side versus cortical. So that's why pathologically, when we talk about disease, most of the disease is going to affect the trabecular bone, because this is the active side. The more activity, if you drive 200 miles a day, the chance of having an accident is higher than somebody who's driving 2 miles a day. So this is the same thing. The chance of something goes wrong with the mechanism happening in the trabecular is much higher. So the two processes that you need to understand that we mentioned last week or last lecture is that we resolve the bone by osteoclast. And then osteoblasts will come and build the bone. So you remove something and then you replace it back. So, and this process is happening in what we call coupling mechanism. They exist in the same time. It's not like, oh, go ahead and remove this bone and then we can wait another month before we start fixing it. No, it happens simultaneously. Areas resorbed, you can see in this histology, large osteoclast sitting in this hole has a name. Hauschip lacuni. And then you can see next to that osteoblast depositing bone here and here and here. So they are happening at the same time. Again, this is not normal, this is a disease process. But it happens all over the body all the time. So you have all this little foci of remodeling all the time, little bit of removing here. So, but in order to keep your bone mass balanced, it has to happen quickly. So if you remove something else, they just have to come and try to build it as quick as they can. So, as I said, happen in random locations. Those are going to be like, oh, this month is going to be my humerus, and then next week is going to be the upper part of the tibia. No, it's random all over the skeleton. And why is that? Why we have this remodeling? Somebody asked me, I forget which class, one of the groups here. They said, why the osteoclast in resort bone? First is optimal bone strength. We develop microfractures all the time. When you exercise, when you run or sit even and hit yourself and stuff like minor things will cause what we call stress fracture is different. Yeah, it's different. It's called microfracture. Stress fractures means that if you do too much of exercise, then you can break the bone actually. Yeah. But microfracture is very tiny fracture you don't see. You don't see usually in X-ray. But over time, they can get bigger. So your bone become weaker. So small, mild trauma can cause a fracture. So the body replace all these cracks, microfractures, and put a new one. It's like I live in an area where it's usually snowing in winter. So every year they have to repair the roads. Why? Because they crack. And if they leave the crack just for a couple of weeks, the crack will be 3 yards wide. So they always go right away, they excavate the old area and then they put a new one. This is exactly what happened with the bone. Anytime you develop microfracture, the osteoclast will migrate, they get the signal, they move this surface of the bone, replace it with a new one. So this is what we call the remodeling. Old one is moved and then you patch it until over 10, 15 years, basically everything is replaced. The other thing that we talked about, we said this is some of the function of the skeletal system, is calcium homeostasis. We have to keep a critical level of calcium in the body especially. And part of this is to bring the calcium which is stored as hydroxyapatite in the bone to release it in the cell circulation. So this is part of the balance. If I need calcium in the body, we get a signal to the osteoclast, we'll chew some bone, break it down, and calcium is coming. Yes.
Sorry, if it's random mutations, then why do they say that the trabecular bone is internal remodeling and the compact bone is surface remodeling?
But this is different. Random, it means it's not as site specific.
Okay.
It doesn't happen only at the particular site. Let's say the humerus now is only happening in the humerus and later it's going to happen in the femur. No, it's random site and it's not really specific. We don't know. It could be your humerus is remodeling more than somebody else, and the other one's femur and so on. That's all random. Yeah. But the other one about the surface is different, internal. So that's important to keep your balance. Regulated by many things, we'll talk about that in the next few lectures. This is biology, this mechanical stresses, hormones like pH and so on. So trabecular bone remodeling, yeah, something else here about before I move to this. So in a normal situation, you should be able to maintain what we call the hormone, the bone balance, as we'll see. So whatever you lose, you have to replace. So the trabecular bone remodeling on the bone, on the trabecular, the bone remodeling on the trabecular surface is a little bit different than the one happening in the cortical bone. So in the trabecular bone, because those bones are thin, so the remodeling happening on the surface. So this is a histological section of a mouse tibia. This epiphysis, this is metaphysis. All these green lines here are the trabeculae, this network. This is a higher magnification. So osteoclast will migrate on the surface and start chewing part of the bone. So that's simple with the trabecular bone because you don't have lamelle and variant system. So osteoclast will come in, they start digging, making the hole. This is the repair, the site, they get a signal, this is the site that needs to be repaired. They keep digging until they cover the area they're supposed to cover. Then right after that, osteoblast will come and fill in this space until they completely repair the defect that happened. So a couple of things you need to understand. First, the osteoclast, you don't need, as I said that before, osteoclast working fast, so you don't need that much time to break something. But the osteoblast will take more of them at a longer time. So it's always, you see a lot of osteoblasts on the side versus osteoclasts, always, because they can break a lot.
The nucleus has something to do. It seems like the osteoclasts have no nucleus.
They are multinucleated, they are multisensitive. No, just active because it's always easy. You can break these tables, in no time, but we need probably 20 people to build it in a longer time. So usually it's 4 times as long for the building. So 1 week to break, let's say, for 3 osteoclasts to make this hole would take probably 20 osteoclasts to fill the same thing in a month. But normally what you do is you end up with a balance. You're supposed to maintain this as a normal process. Whatever you lose, you continue, bone homeostasis. Whatever you lose, you repair. And then usually by the age of your mid-20s to 30s, you reach what we call peak bone mass. This is the best bone you can get. That's why you need to exercise and eat well in this age, because this is going to be your best, because after that you start losing, because with aging. But then the longer you maintain your peak mass, until let's say 50 or 60, then the chances that you're going to lose or have something really pathological is less. But if you don't reach really good peak mass and then you start losing even early, this is going to be a pathological process. So that's now something that you have to understand. You're supposed to exercise all the time, not only when you're young, because if you stop that, you're not going to maintain. I mean, mechanical stresses are the part of your life that maintain your bone homeostasis, so because you can build. So that's why, because usually the osteoblasts would age, and then after that you start losing, especially in female, as we'll discuss. Okay? Now, the remodeling in the compact bone, or the cortical bone, again, just for you to remember, we have a virgin canal, we have the osteons, and these are the main things that happen here. In the cortical bone is that it's called internal remodeling. So because the trabeculae are thin and they are exposed to the surface where they have all this, monocytes and osteoclasts can form, they easily access the surface. But in the compact bone, it's very dense. Maybe some of the surface outside can get access to these cells, but the ones inside, which is quite thick, where the osteons are, they are not free surface, so they end up internal remodeling, because now the cells are going to come from the blood circulation, where we have the central artery. They go outside and then they chew inside the osteons to making the remodeling in this pattern. So this is a cross section of a cortices osteon. So you're looking at the bone like this, okay, like that. and then be a starting point at one of those osteons, or it doesn't have to be every single one, it could be more than one. The osteoclast will be released from the circulation and then start chewing in a circular fashion, drilling inside the osteon. So the osteon is like this, and then I'm going to actually drill it. زي اللي بيحفروا كوسه. انتوا الولاد بس ما عارفين ازاي بيحشوا المحشي، يعني هو بيعمل المعجن بتاع السكينه دي. فيقعدوا هو يحفر. It's the same thing. You just keep drilling كويسه. They keep moving, so they're chewing it from inside out. So they will remove this, but in the meantime, osteoblasts happen to move right away. Again, we can't keep the defect for a long time, otherwise you lose. If this happens and then everybody, oh, let's wait another 2-3 months, you have a lot of bone losses, but you can't repair. So this is the cutting which is happening with the osteoclast, followed by the repair or the filling with osteoclast right after that. It will take longer time and more osteoclast, but we start the process right away. So if you look at the cortical bone, you will find many of those foci, internal remodeling. It's not going to be on one spot again. It's going to be multiple. Those osteos are tiny. So you can have many hundreds of those in one bone or two bones, like all drilling and filling and drilling and filling. So this is how the internal remodeling is happening in the cortical bone. They call the area where you start the osteoclast drilling through this bone, we call it the cutting cone. And the one that's osteoblast making, they call it the closing cone, because you cut, and then you close. It looks better in this illustration, just to give you a better view. See, this is the cutting cone, osteoblast. Now we're looking on the bone like this, longitudinally. So they cut, and then the osteoblast will fill behind them. In a cross section, osteoblast surrounding the osteon here, and then they keep adding the osteoblast filling. So they cut inside out, but they fill outside in, because you drill, until you have the hole, and then the osteoblast outside will fill, and put the layer, and then close it again, and then the artery will be in the middle. Is that clear? You have to imagine this. So, I show you this picture before, and if you just focus on this, what we call first generation. This is osteons, correct? And between them, what is this? Interstitial limit. So, I told you I'm going to talk to you about this last picture. So now look at the second, what we call second generation. When the remodeling happened, it doesn't go exactly the same site of the previous osteon. They're off, or the shape can be different. It can be a little bit oval instead of rounded. So what you end up, when you drill this area, you don't drill this exact area. You drill a little bit off. So what you end up with is remnants of the osteon. And the third generation will come, the same thing will be off. That's why those remnants of the old osteons are the interstitial limit. Because somebody was asking me how they form. You don't form, they exist as osteon, and then you keep drilling, but then the drill doesn't go exactly in the same place. So whatever left over the osteon, and then keep going. So it disappear, and some other will come, and so on. فؤاد ما تعرفش تتكلم، انت جاي متأخر عمال تتكلم. وبعدين تقول ده بعمل summary lectures. كويس. Mineralization. مش تتكلم انت؟ لا يا راجل. لا نظر كده لا ما بظبطش حد لا. لو على الأقل مش أصلي لا ما تتكلمش. تتكلم معاه. ايوه لو جبت سنة مش كلام.
لا لسه الكلام.
It just irritates me a little bit. أنا بنسى. لما حد يقعد يتكلم وانتبه عليه أنا بنسى بالتوقيت.
You said the osteoblasts outside in, so where did they exist? You said they damaged from inside out, the blasts come to the surface?
Not the surface, just inside the osteon structure itself. The monocytes are in the blood. So having the osteon, you have a vessel, correct? So they're going to migrate from the blood to the outside area.
And go back in.
No, they will die also. No, they're going to escape back in? No. They either exist for some time to active, or they can actually come back. They can stay inside the lumen of the osteon. And the osteoblasts are already existing during development also as osteoprogenitors. They're not active yet. Osteoblasts can stay also not active. It doesn't mean that if the osteoblasts then have to resolve with the bone, no. They're trying to sit on the surface only. Yes.
Doctor, so you said the interstitial lamellae, is it formed from the
remnants of the old osteon which didn't get remodeled, which didn't.
Yeah, the part of the osteon that wasn't really remote, it wasn't chewed.
Yeah.
You know, you drill something but not drill all the way, but some will be left. So these are the lamellae, that's why you take the filling in. So as if you are fitting something.
Why is the second generation of osteons off from the first generation?
No, I mean, because there is no pattern, there's nothing to tell them that you have to follow this. You just keep drilling, this is how it happens. You know, they just come and they chew an area, they get a signal and they stop for some reason, we don't know. It doesn't follow with the, you just go and carve the pattern, no. You just drill a hole. So they come, but because they're coming from the blood vessel in the center, they usually close to this area, but doesn't have to be exact.
Yes, can it reach into the lumen of the bone, like the osteoclasts, when they're drilling, could it reach into the lumen of the bone? And
No, the cortical bone is quite big, relative to the size of the osteo. Talk about millimeters.
Yeah.
So they will try. They can reach to the side, but doesn't mean they have to go all the way. There is a signal that tells them where to stop.
Oh, okay.
Yeah,
So
yeah.
there's no danger. There's no.
No. I mean, with the disease is different. When you
Yeah.
come about diseases, whether with the trabecular or cortical bone, this can go beyond the control because of different things, different mechanisms. But normally it shouldn't. There's something called cortical porosity. We might talk about that later. When you look at the X-ray or let's say CT scan, you can see little holes in the cortical bone, which is the presence of those little either remodeling units or also because of the vessel. But in a disease process, we can see this way bigger, but this is not a normal bone. So the bone mineralization, we said, firstly the bone will be deposited as organic matrix only with type 1 collagen, and then the matrix will be filled with calcium phosphate, the hydroxyapatite crystals. So this process is not really clear yet exactly how it happens, so I'm going to simplify this to some extent. And I told you before also osteoblasts deposit the matrix, but also they help with the mineralization. So what they do, they release this vesicle, the vesicle is this small structure that buds off the membrane, and they contain what we call alkaline phosphatase. It's an enzyme that stays in this vesicle. They migrate, so this actually flipped. The bone is this side and this is surface down here. Osteoblasts will release all these vesicles containing alkaline phosphatase, and this enzyme will be the attraction for the salt, calcium and phosphate, to bind to these vesicles. So they start accumulating and coalesce and making the crystal, then crystallize. And you can see they keep adding more on the vesicles. So this green is the hydroxyapatite, and then they crystallize, they coalesce, they align and stay parallel with the fiber. So this is simply how the mineralization happened. So all start by the alkaline phosphatase. We'll talk about alkaline phosphatase because it's a very important indicator of the bone development or healing. Now we're talking next about the bone formation, osteogenesis. And we have two types, either what we call intramembranous ossification or endochondral ossification. Intramembranous ossification, here the bone developed directly from mesenchymal cells versus in the endochondral ossification, the mesenchymal cell will make a template by cartilage and then it will be ossified. So in the intramembranous ossification, we can see this evidence about the 7th to 8th week of gestation in the human. So what happened is, mesenchymal cell will get a signal that they need to go to these areas, which is the flat bone, skull, sternum, and pelvis, and so on, and the mesenchymal cells will aggregate. Mesenchymal cells, we said, they are up in the tree when it comes to differentiation, because they can differentiate to multiple things, not only bone, but cartilage, fat, muscle, and so on. So in the case of the intramembranous ossification, the mesenchymal cells, which you can see here, which is not really have any clear demarcation how they look. I don't have a feature that you can tell you, but we know it is. And they aggregate in this area, and then they will differentiate into osteoprogenitor. You know, for this, the flat bone, we need to make bone directly, so it becomes osteoprogenitor. Osteoprogenitor, once it differentiated, they're committed to be osteoblasts. So they make osteoblasts. Osteoblasts will deposit the organic matrix, and then here's the beginning of the ossification process. So after that, you keep seeing that the intramembranous ossification keeps happening at the surface. We have a little bit of bone, and then osteoblasts keep adding more osteoid, and then we'll demineralize, and then we'll take the bone. Then osteoclasts will come through the blood, and they start carving these areas, making what's trabecular and what's cortical. And then after that, the bigger it gets, the osteonal start to develop because of the penetration of the blood vessel. You go inside the area which is supposed to be cortical bone, and then the osteoblast will put the layers of osteols. Versus if it is trabecular, osteoclast will just carve through the piece of bone, making them thin. So this all signaled through the osteoclast, they know exactly what to do. So you end up with this intramembranous ossification. In the endochondral ossification, actually the mesenchymal cells, also they go for the aggregation of the sites which are supposed to be the long bones, but under influence of certain things. Now the mesenchymal cells can do many, many things. Everyone has its own direction why it should do. So for the endochondral ossification, we have the fibroblast growth factor and bone morphogenetic protein. Both of these signals that tell mesenchymal cells, no, don't do bone now, do cartilage. So they express, making those cells can chondrocyte express the type 2 collagen, and they make a template that looks like a bone, which is this one. This is a longer bone, 2 epiphyses, and you can see the shaft here. I mean, it's short, of course, it's embryo, it's all made of cartilage, there's no bone here. So this is the major difference between the two. Membranous ossification, mesenchymal cell, osteoprogenitor, osteoblast. But in the endochondral ossification, mesenchymal cell, chondrocytes, and then ossification. So it's hyaline cartilage. The first site, or where we can see actually ossification happening in this area at the mid shaft here, is called collar bone. It's produced by osteoblast differentiating from the perichondrium. Perichondrium will actually start also to be periosteal and then become able to make osteoprogenitor cell and osteoblast. And you can see in this histological image and in the cross section here, this longitudinal section of long bone developing, you can see this red pink area. This is the collar bone, and you can see if you cut in a cross section, all the bone is still cartilage, the template, but then you can see very, very small areas of what we call the collar bone surrounding the long bone. Then after that, this is the beginning. After that, the long bone develop what we call centers of ossification. We have primary center and secondary centers. Primary center happen probably by the end of the first trimester, about 12 weeks of gestation. Happen in the mid shaft here, and then the other two secondary ossification centers happen at the epiphysis. So we have two of them, because we have one on both ends. This is actually happening close to birth, a month or so before the delivery. The second ossification center start to develop. So what happened is, the chondrocytes start to enlarge, which was the middle. You remember there was some collar bone here, but there's a lot of cartilage. Chondrocytes start to become hypertrophied. When they get big, they become also unable to get enough nutrients, and the diffusion decreases. So what happened is they started dying and also decompressing all this matrix between them. And the matrix, because of the hypoxia and the blood coming, they started getting mineralization. So they call it calcified cartilage. So the bone, osteoblast will come here and then start depositing bone on top of what we call calcified cartilage. So the cartilage will calcify because of the mineral deposition, it's not bone yet. Then osteoblast will come and then they sit on top of that and they start depositing bone. So this is just an histological images, high magnification that show you this mechanism. The light color area is a cartilage, the calcified cartilage. This is the remnants of the template. And you can see on top of that all this new bone added on. So until it disappears, it will get dissolved and disappear. But because there was a template of cartilage, the osteoblast take advantage of this, keep depositing the bone on top of it. So they call it the mixed speckle. You might see some of the labs. The color here is not H&D, it's something called Miller stain, but usually the older the calcified cartilage will look lighter. If it's H&D, it will be like light pink, whereas dark pink. And you can identify that, but there's no osteocytes inside the bone. Yes.
So what happens to the calcified cartilage after the?
It gets reabsorbed because they have osteoclast and there's something called chondroblast or chondrocyte. Chondroclast, I'm sorry. They reabsorb.
The minerals will also get absorbed with the besides calcified cartilage?
Yeah, it will be released in the extracellular fluid and then will be taken back inside to make the bone. Some get wasted. Yeah, because once you break anything, we'll talk about that, all the components will still there and then it can be recycled. Yes. Because it's going to be used for mineralization. But it's not going to stay here, it's going to break, then it's in the extracellular fluid. Yeah. Looks like somebody else did something. Okay, so to summarize the endochondral ossification, we're starting with this hyaline cartilage template for the long bone, and then the collar bone at the side will be primary center of ossification. The artery will invade, And then you can see the process of ossification will happen in 3 directions. First, from those two, if you see this is down there, which is the secondary center, but also from the primary going up. So the bone will turn like this. And also in the meantime, osteoclast will start carving the area, which is the marrow. So it's important to see that the primary and secondary ossification, they both close to this area, to the metaphysis area. Is that clear? Yeah, ossification happens in the middle, move up, but from the secondary center, move down. But then they meet in the middle here. This is important because we're going to be talking about that next. Because of the growth of the bone. So all this template, the growth, what was the template for the long bone would ossify except 2 sides. The articular cartilage, which is articular surface, but also the growth plate, the epiphyseal plate. So this is actually where the growth is going to happen. So that's why your bone gets longer. Because if you ossify the whole bone, it's become all bone, you're not going to grow. That's it, you're going to stop getting taller. I mean, you can gain weight, but not. So this is articular surface going to stay intact, this is going to be the joint. This area is going to stay as growth or epiphyseal plate, and then it goes cartilage, and then as long as this is still open as a cartilage, you will get taller. So many of you still probably still gaining some height. As if you need it. So the continuous growth process, especially for him, I think that we not good. So when you when you look at this, we actually divide this into many zones. The real cartilage is hyaline cartilage, but have specific zones that we discuss. The first one is called reserve cartilage, which is the one close to the articular surface, followed by proliferation, hypertrophy calcified, and then the ossification zone is the one closer to the bone marrow. So this is just a picture, we'll talk about those in detail. So the first one is called the zone of reserve cartilage. This is the articular surface up here. This is inside the bone marrow. Yeah. So the first layer is called the zone of reserve cartilage. There's no cellular proliferation. Reserve, like you have people waiting until they are needed, so that's a function. Just sit there, not really much activity. Followed by the zone of proliferation. This is the zone where the chondrocytes start to develop. And usually you can see them in this, organized in this column. So you can see the reserve cartilage, you see that in the lab. There are no really pattern, all the cells are scattered, but if you look at the zone of proliferation, you identify this because of this column. When the chondrocyte divide, they don't make those isogynous groupings, they rather stack on top of each other, making these columns. So that's why you can identify the zone of proliferation. And then, followed by what we call the zone of hypertrophy. After that, like the cartilage usually do, the chondrocytes become bigger. And you can see the difference. They're still on this column, on those stacks, but they're much bigger. You can see the clear area surrounding the cell, and the lacunae in the cytoplasm is clear, and you can see they're very active metabolically, depositing all these type 2 collagen for making cartilage. But then, again, like we did talk about in the ossification in the beginning, something's going to happen. Something is going to trigger this as a hypoxia area. We need blood because we can begin to fever. So they secrete what we call VEGF, vascular endothelial growth factor, another stimulant that will tell them we need blood vessels here. Once the blood vessels come, they also will bring minerals with them, and then the cartilage, the matrix between those cells will be calcified. So we get again calcified cartilage one more time, and after that it's going to be zone ossification, where on top of the calcified cartilage, the bone will be deposited. Okay, so this is how the transformation of in the growth plate. Okay, you just don't calcify cartilage and then you just sit down. So how we grow is going to be important for you. So because we replace what's missing. So if you imagine the growth plate is this one, this was all these 5 layers, reserve and all the way to the ossification. So because of the ossification process, the very end part, which is the hypertrophy, will be now replaced by bone, correct? So I'm going to cut some from here. But then the proliferation and the reserve will add another layer on top. So let's say this is 5 centimeters. I lost one to the bone, but I add another centimeter. So that's why you keep going taller, because you're actually pushing the growth plate up. It doesn't change, it should keep moving. It will stop when actually we reach the age where you stop growing. Different influence, genetic factors, hormones, and so on. We'll start adding, cutting, but we cannot add much. So we cut 1 centimeter, convert it to bone, but we'll add half centimeter. Another 1 centimeter, that still disappear. So in this case, this would be stop growth. I hope you still didn't reach this, because it's still here. So that's why this is how actually we stop. As long as you have this epiphysis open, you call it open epiphysis. The epiphysis is still open. And then you can give, and this variation between people. Some people at age of 15, 16, they stop growing, get much taller, and other until 21 or something. Those are the tall people usually. They have this open for a long time. So this is actually how we get it. So it's the same thing. And just a picture showing you, can see the shift with the blue zone here, which is the growth plate will shift up. So everything goes up. So that's why as long as you're having this open, you'll be. Something else that you notice, I don't know if they show you X-rays yet in the lab? Did you?
Some X-rays.
Because if you look at the X-ray from somebody who's young, his epiphysis is still long. You see a dark zone in the close to the just before the epiphysis. It will be a clear area, black area, because the growth plate is cut. The cut is not going to be opaque, so it's going to be black, like air. So if you look at one that's all ossified, it's all born is somebody who's adult, probably over 20 something. This also they use it for toxicology and forensic medicine. Sometimes you differentiate somebody's remnants, is it was a kid, or especially from those mummies in Egypt, or the kid or something because of this epiphysis. Because if they die and they're still growing, this will disappear, but the bone is still, so you can find the gap in there. So an X-ray holds, and it's also important clinically because if a kid fall and cause a head fracture, and the fracture come close or go through the growth plate, this is a problem. Because one limb will grow probably longer than the other, or the other one will be shorter. So a lot of those kids I've seen with a shorter arm, and it's not going to be one of those who really very small arm, but it will be an inch shorter or something, or lengthy or something. So this commonly because of this, the fracture happened through this, and nobody pay attention. So it's always you have to be careful if somebody came with a fracture with the kids. You have to make sure the growth plate is safe. And the bone also grow in circumferential, or we call it oppositional growth. So the bone is not only getting longer, but in the meantime also get wider. So this happens because of the periosteal deposition. We said that the periosteal have two layers: outside layer, which is connective tissue, dense connective tissue, but then we have an inside layer, which is osteoprogenitor cells. These are the one will be activated, they can osteoblast, and osteoblast will be deposited in the bone. So the bone will get growth like this, exponential. But in the meantime, you can't have the marrow space narrow, so we have actually to open it. So osteoclast will carve it in, so the bone grow like this. Yeah. And it's actually better to have a wider bone. Please stop talking, the one in the back, I can hear you. So if it goes bigger than the, see, I really, yeah, it's better to be wider. Why? Because if you look at the forces that this bone can take, is better. If you have a thinner bone that's all solid versus the bone that's actually wider and have a hollow center, this will be stronger. The one has a hollow and wider, it takes the trauma, it can stand the trauma better. So that's why they have a bigger bones, then you have a better chance of resisting certain fractures. So that's why the remodeling of this process is important for us, and of course we need also the bone. Now, this just to summarize, we have intramembranous and endochondral. Intramembranous, we have the mesenchymal cell, osteoprogenitor, and osteoblast, deposit bone. But in the endochondral, we have to have this cartilaginous plate, hyaline cartilage, and then under influence of hormones, this will be ossified as we discussed. Blood supply, just to quickly cover this. Bone is very, very vascular. If you see, if somebody have a big fracture, and the fracture because of the distribution of the blood is we have main nutrient artery here, one or two. A lot of time you can see that in the gross lab. If you look at the dry bone, look at the shaft, look at the middle. You'll find sometimes a hole, big hole. This is the nutrient artery side. And then you can see at the epiphysis, smaller but multiple of those. And then they shoot inside, they pass through the cortices, and then they branch inside those big sinusoids, especially in the beginning, inside the bone marrow. Well, the problem with the fracture, if you have a big fracture that actually sever the bone away from each other, you can cut one of those major vessels, and they bleed like crazy. I know somebody's, my friend's father-in-law, Haman, died because of the fracture of the femur. He was a big guy, like 150 kilograms or something. And he fractured his hip, and they put him in the hospital. Oh, he's conscious. And he lost like 2 liters of blood, nobody noticed, because his thigh was that big. Nobody, 2 liters, not very sure. But nobody paid attention that, yeah, we have this big fracture, it probably cut a big artery. So in 2 hours, the guy is collapsed and dead, just because of fracture. So things like that, you have to pay attention. It's very versatile. Not all the fracture will do that, but if it's small fracture at the surface, will cut a few blood vessels and develop hematoma. And hematoma is important for the healing. So we have some also periosteal vessel at the surface here, but it's not the main. The other one I want to show you about the blood is interesting because those neuter arteries, you don't, we said that there's a lot of blood vessels inside the osteum. They don't come directly from the neuter arteries coming from outside. They rather shoot inside, and then they loop and back inside the cortical bone to make those vessels. It's just interesting. I'm not going to ask you about this, but it was a research article I like and they took it. But it's funny how this actually is made. The bone marrow, just make sure that you know that we have a lot of adipocytes, especially in the adult bones. Just one last thing about fracture. But the only thing is just when people talk, because I do really lose focus. So the fracture healing, I'm going to cover that a lot in pathology, but it's very interesting because you see a lot of things. You see the remodeling, and you see endochondral ossification, which it doesn't happen normally except the fracture. If you have a big fracture like this one, and you have a big gap, if you have a small gap, the periosteum will hold, and all this osteoprogenitor will come, osteoblast will build, filling the gap. If the fracture is big and there is a gap and there the bones are separated from each other or the segments moving, then you end up with a callus, but the callus will form as a cartilage. Because osteoblasts cannot migrate, they need a template to jump on. So the hematoma will develop, and then you can find a cartilage template. And on X-ray, they call it actually a soft callus. It's a callus, it's not hard. Because of the, and sometimes it's important to see that, you should see the shadow. You know, it's a big fracture, but they're healing. If they don't make the shadow and still nothing, they probably need to fix. You need to put a rod or blade to bring it together. Otherwise, if they have the soft callus, and then of course will calcify. After that, it's gonna heal. If not, then you have to make sure that you bring these bones together. I just want to finish one thing. And in the same time, after that, you can find this very ugly, deformed bone after the healing. Then the remodeling that we talked about is going to happen. Osteoclast will keep chewing and cleaning things up so the bone will look back to normal. Yes.
So they have to be close to each other?
Yeah, that's why in the surgery, most of the time, as long as they're far, you're never going to heal. If they have a little bit of a gap and callus, soft callus form, they will heal because it will be bridged, the callus, the cartilage, the soft callus, the cartilage, which means the bone is going to bridge over it and build. If you can't, then you have to put surgery. You have to screw and plate and then just put things together. Or if fragments, you have to put something in the middle. Because I worked with orthopedic surgery a long time ago. So I know this. The third, attendance, you go home.